How was dessert? I make them wait till now for dessert.
Oh.
Yeah, I don't give you dessert at lunch, I was telling them. I'm going to introduce our two speakers to the left, and we're going to get started. First to my left is Dr. Blindauer, a professor of neurology. Oh, thank you. Please save the love lighters for at the end. Dr. Blindauer is a professor of neurology and the director of movement disorder program at the Medical College of Wisconsin. She specializes in the care of patients with Parkinson's disease and other movement disorders. She has an additional expertise with deep brain stimulation for Parkinson's and Botox injections for dystonia. She is also a member of the Wisconsin Parkinsons Association's Medical Advisory Committee. Welcome, Dr. Blindauer.
Hi.
To her left is Dr. Finseth, a movement disorder specialist at Aurora St. Luke's Medical Center. He believes in the role of the physician as educator to empower patients and their caregivers to lead the best life possible. He provides management of movement disorders including Parkinson's disease, tremor, dystonia, and deep brain stimulation programming, and performs Botox injections for dystonia and other conditions. Dr. Finseth earned his medical degree at Ohio State University and completed his residency in neurology and fellowship of movement disorders at the University of Colorado. He is also a member of the Wisconsin Parkinsons Association Medical Advisory Committee. Welcome. All right, because of the applause, we are now done. No. So, a lot of you gave us questions ahead of time that you submitted online, and some of you have given us questions. We're hoping just to answer as many of those as we can today. So with that, we're going to start. One of the biggest questions that was asked, and I'll start with Dr. Blindauer, is what can be done to improve freezing issues in Parkinson's disease?
Okay. So freezing, many of you know, is this okay or am I too loud?
He's fixing it.
I'm okay, okay. All right. So freezing typically involves getting stuck when you're walking. So you might be having trouble getting started, or perhaps if you're in a doorway, you get stuck, or if you want to turn, change direction, you might have trouble moving. So not everybody develops freezing. It tends to occur later in Parkinson's. So for those of you who haven't experienced it yet, just a little explanation of what freezing is. So what we can do for freezing is first figure out when does it happen. For some patients, maybe it's when you're in the off state. So you haven't taken your medications yet for the day, or maybe your medications have worn off and you're kind of in between doses. So if that's when the freezing occurs, we adjust the medication accordingly. So perhaps take your medicine in bed, let it kick in, and then you can get up and walk, or adjust the medication so you're not wearing off in between. Physical therapy can be very helpful for freezing. Our therapists oftentimes will teach people strategies. You know, when you get stuck, how do you get yourself going so that you don't fall? And certain other medications are thought to maybe be helpful for freezing, like amantadine or the MAOB inhibitors, which are selegiline and rasagiline, but I'm not 100% convinced. And sometimes using a walker or visual cues, something that helps to draw you forward, will overcome the freezing. Do you want to add anything?
I think you covered it well. I think I would highlight that really addressing off periods, as the majority of freezing occurs in the off periods, is the way we tend to start.
Okay.
Excellent, thank you. One of the other symptom questions we had, and I guess I'll start with Dr. Finseth this time, are hallucinations common for people with Parkinson's disease, and what can be done to either handle and or treat hallucinations?
Hallucinations are fairly common, usually in later stages of Parkinson's disease, but can occur at an earlier stage. And these are typically visual in nature, often out of the corner of the eye, and might be an illusion of motion, or sometimes can take the form of figures. And then sometimes those are more well-formed and might look like animals, or children are common. And they typically don't speak. There are sometimes some sensory hallucinations where people feel things that aren't there. And I think the rates of how often this occurs, maybe in the 50 to 60% of people will experience it at some point in their Parkinson's disease. How we handle it is a little bit complicated, but it would basically involve removing medications that could aggravate the hallucinations, and that might include medicines like amantadine or some of the dopamine agonists like ropinirole or pramipexole, or any bladder medications. And then switching more to just using carbidopa levodopa or mostly carbidopa levodopa for management of the Parkinson's. And then there are medicines we could add that can help suppress hallucinations, and those are medicines like Aricept or Exelon, or medicines like quetiapine, or a newer medication called Nuplazid or pimavanserin.
Excellent, thank you. One of the other questions we get a lot of, and we'll start again with Dr. Lindauer, how is vision impacted by Parkinson's disease? I've had some people tell me they have really bad vision issues. Some people say they've never had any. So is there a correlation with vision issues in Parkinson's disease?
Actually, Jeremy, there's a few vision problems that can occur uniquely to Parkinson's, and one is called convergence insufficiency. So convergence is when we want to look at something near in particular, our eyes actually pull together to focus on one point. And if those eye muscles are weak and you're not focusing on one point, you might have double vision. So it makes it particularly hard to focus when you're reading. Many patients with Parkinson's will notice a little bit of difficulty with tracking when reading. You get to the end of the line and our eyes should automatically go to the next line, and that tracking ability can be a little bit impaired in individuals with Parkinson's. Some people will feel their visual acuity is a little bit blurred, and that can oftentimes come from dry eyes, because people with Parkinson's don't blink as often. And when we blink, the tears are wiping our eyes, keeping the cornea moist. Sometimes medications dry the eyes a little bit. And then the other vision issue in Parkinson's is just a loss of what's called contrast sensitivity, and that's the ability to see differences in colors or shades. So that one's a little bit more subtle, not something that maybe a person would notice on a day-to-day basis.
Thank you. I think that hopefully answers a lot of questions on that one. Here's one of my favorite questions, because I hear this at support groups a lot. How do I know if it's my Parkinson's symptoms or I'm just getting older?
I'm glad he's getting that one.
That's a really hard question to answer succinctly. And it also can be hard even for us to answer. So I think it's hard for patients, caregivers, anyone to say definitively whether something could be Parkinson's or aging. But that being said, there are certain symptoms that are highly characteristic of Parkinson's disease, and when they're occurring in a patient with Parkinson's disease, the Parkinson's disease kind of gets blamed, and the Parkinson's gets blamed for a lot of things. For some things that come and go, sometimes people have some symptoms throughout the day, and you're wondering, is that part of the Parkinson's? Sometimes we use how it correlates with the timing of their medication as to whether that might be a part of the disease or maybe a side effect of medication, or maybe it's more of a symptom from aging or fatigue. So those are some of the tools I use. I don't know if you have any helpful hints on that one.
Yeah, I agree. Sometimes it is hard. Somebody says, I wake up in the morning and I feel stiff. Well, that starts to happen after age 50. I can attest to that. So I like your thoughts of if it seems to respond to medication and maybe change a little bit dose to dose, that points more toward Parkinson's rather than just being stiffness from aging and so forth.
I'm glad to know I'm ahead of the curve. I'm stiff and I'm not even 50 yet. One of the other symptomatic questions that was asked, and I feel bad because I think I asked you this once before, what can be done with constipation in Parkinson's disease? Such a great topic to talk about now that they've all had a nice dessert.
So constipation is a common problem in people with Parkinson's, almost more common than having tremors. So at some point in the course of Parkinson's, almost everyone might experience constipation. And I think sometimes people are embarrassed to talk about it, but you should, because it impacts quality of life. So I think the first thing you need to do is drink lots of fluids. And that sometimes is difficult because many times people with Parkinson's also have overactive bladder. So you said, well, are you kidding me? You want me to drink a lot of liquids, but then I'm going to have to run to the bathroom. So I understand it's being caught between a rock and a hard place, but you have to stay well hydrated. And then eating a lot of natural fiber in your diet, fresh fruits, vegetables, salads, natural fiber whole grain cereals. And if just those methods don't work, there's a lot of over-the-counter products that are helpful for constipation, stool softeners, and a product called Miralax, which is kind of a natural vegetable compound that just increases the moisture in the stool. And for some severe and problematic cases, I sometimes refer patients to GI to have some additional medication options or ideas to help.
Great. I would just add that the Wisconsin Parkinson's Association has a little card on constipation, and that sums up pretty well what Dr. Blindauer said. And in addition, has this recipe for what's been termed power pudding, and it's a good way to get more fiber in a natural way to treat constipation.
Thank you. One of the questions, and I'm going to try and phrase it as politely as I can because somebody asked it. As we look out on this audience right now, it's extremely Caucasian. Can you give us kind of an idea what the breakdown is on how Parkinson's affects different ethnicities and what you see within your practice? I know it's not an easy question, but I think I'll throw it out, and it's come up a couple times today, so we thought we'd address it.
Okay. Well, from the studies I've read, Parkinson's disease affects all ethnicities at essentially the same rate, and so it is not more predominant in one race over another. And so the fact that what I see in my practice is primarily Caucasian patients, but I don't know all the reasons why there, but there are certainly healthcare disparities amongst different ethnicities within the United States and within Milwaukee, and so I think it's a complicated issue, but it really shouldn't be more predominant in one race than another.
Thank you. That was not an easy question.
Yeah.
So I'll give you a real easy question, Dr. Blindauer. It's not easy. Somebody had asked, is Parkinson's disease hereditary?
Okay, that's an important question because I think many people are concerned, well, now that I've been diagnosed with Parkinson's, what are the risks for my children? So the honest answer is, for the most part, it's not. We estimate maybe 10% at most of cases are hereditary and run in the family. A greater risk to run in the family happens with younger onset Parkinson's, and we define that as age 55 or below. A stronger genetic contribution if you develop Parkinson's after age 55, less of a genetic contribution and less of a risk to your family members.
Excellent, thank you. Yeah. One of the other questions, kind of going along the lines, I had a woman say, I was a nurse 25 years ago, I knew 5 people with Parkinson's disease. Now I know hundreds of people with Parkinson's disease. It seems like the incidence and prevalence is going up in the US and Wisconsin. Is that true? And if so, can you maybe explain why or what the theories may be?
I don't believe that to be true, but I don't know if Dr. Blindauer knows of any other data. But I believe the prevalence of Parkinson's disease has remained quite steady over time, but if you know anything different.
Yeah, I think it will probably increase, or it might be increasing just because of the aging population, because it is more prevalent as you get older, and we have aging baby boomers, and we have a lot more people who are living in their upper 70s, 80s, 90s. So I think it might seem more prevalent, but it's more of a side effect of an aging population, and not really that more people are being afflicted by Parkinson's than would be expected.
That's a great explanation, thank you. Here's one I think for both of you. It came up a number of times. Anything on the horizon that you know of for new medications or treatments, not just for Parkinson's disease, but maybe for some of the symptoms of Parkinson's disease as well?
So on the horizon, I would take to mean not yet commercially available. I think the thing probably closest to market that I'm aware of is we expect that the FDA will approve this subcutaneous apomorphine pump, and this would be a way to administer the drug apomorphine, which is currently available in an as-needed injection called Apokin, but in a continuous fashion through a pump that pumps it into the area just below the skin. This has been available in Europe for I think 5 or 10 years or so, and would serve a similar role as products like deep brain stimulation or Duopa currently serve. But I think patients might be more willing to adopt this treatment based on that there's no invasive procedure to place it. So I think that would be the main treatment I would think of.
Yeah, I agree.
So I'm trying to think how to ask this question because it came up a couple times, and I could be blunt, and the question was, where's a cure? But I don't think the answer is that easy.
Yeah.
So I think it would be, what do you know is going on in research that is probably will be pushing us towards, if not better treatments, maybe better, I don't know if cure is the right word, but better things out there to help either stop or slow the progression of Parkinson's disease and now and in the future.
Okay. So I've been in the field for a long time, so about 22 years, and I've seen research changing, and we're at a really exciting time in Parkinson's research. So for 10 years ago, 20 years ago, we were looking at more treatments to treat the symptoms, and creating things that maybe were similar to what was already on the market, which we would call a Me Too drug. So the research now is breaking new ground because we're actually looking at, can we slow the progression? Can we cure Parkinson's? So we're looking at some kind of scary options, chemotherapeutic drugs that might be attacking the pathology, immune therapies that are looking at attacking the Lewy body and the abnormal protein alpha-synuclein. So compounds that are they're a bit more frightening to be studying in clinical trials because we're not quite used to that as Parkinson's physicians, but it's just a complete 180 from where things were 10, 20 years ago. So I'm very hopeful at this point where the research is going.
I agree that I think the research is moving forward. There's been kind of a frame shift in how we think about Parkinson's disease for the last 10 to 15 years, and now the research sort of stemming from that is entering more into like phase 2 trials at this point, and we're all crossing our fingers that these work. And we're hoping that they at least can stop or slow the progression of the disease. Cure is a hard word, but anything that would be able to slow or stop the disease would be absolutely amazing.
I agree. Anything that stops it or slows it, I think, is a great start.
Yeah.
The other one we get a lot of questions on, we touched on this last year. I'm going to let the guy from Colorado off the hook for a minute, Dr. Lindauer. Can CBD oil help with Parkinson's disease symptoms? And if it's not, if it does, what does it do? If it doesn't, why doesn't it? I guess is the best way to
Wow.
put it.
Okay. So you won't let me punt to the gentleman from Colorado. I think.
We'll get the marijuana question.
Oh, okay. All right. So I think the first problem with CBD oil, I kind of get on my soapbox when my patients ask about it, is that it's not regulated. So you never quite know what you're getting when you buy the product off the street. It might have no CBD oil, it might have half of what it claims, or maybe it has the full potency that's on the label. We also don't know what impurities are in there that could potentially interact with other medications. So the product, as it's dispensed now with no regulation, leaves you with the question, did I really buy what I thought I purchased? So that might be a reason it doesn't work. As far as treating symptoms, we just do not have enough research to tell us that it works. So there's small studies that are done. Some show maybe there's a little benefit for dyskinesia. Some show maybe there's a little bit of help for tremor. On the flip side, somebody does another study and it shows that it doesn't work. Or the research has been done in what's called an open label fashion. That means there was no placebo group. So people took the drug thinking, oh, I'm taking something, I think it's going to work. So maybe it just worked from the power of positive thinking. So not a good, rigorous, randomized control trial like we do most of our other clinical studies. So I think for now the limitations are there's no regulation in production, so you don't know what you're getting. And then we just don't have research showing that it does help.
And I think that's the biggest thing I hear people all the time, Dr. Blindauer, is the research isn't there. The research doesn't show. I see somebody every day who tells me this is what it does for me, but the research doesn't back that right now. So thank you.
Yeah.
Anything to add? Agree?
I mean, I agree. I would just add that I generally don't encourage my patients to seek it out, but if they do, to start low and go slow. And most of the patients that have sought it out have just come back and said, it didn't do anything. And so that's from a practical perspective, who has seen sort of 20 or so patients go through the process of trying it, and it's a fairly expensive compound, that it doesn't seem to do much for them. So that, while that would be great if it does turn out to be useful, we don't know it to be, and that's not a very good track record thus far in terms of what I've seen.
Thank you both. We had a couple people out here who DBS boost. We've had people with DBS. One of the questions came up, what is the most common misperception or misunderstanding about DBS in relation to Parkinson's disease? Start with Dr.
Sure.
Finseth.
I'm not sure I know which one is the most common. I guess I would say that just kind of the timing of when it's appropriate in the disease is probably the most common thing that I run into. And this is both, I don't think patients often have a great understanding, as well as referring providers don't have a great understanding. But I think there's this kind of sweet spot in Parkinson's disease that might start maybe 4 or 5 years after diagnosis, but before some of the symptoms that come later in Parkinson's disease start, where people start to have problems with falling backwards, or more thinking problems, or problems with their swallowing. And if patients are in that time and are having problems with consistency of medication, or their tremor just doesn't seem to respond to the medication, or they can't really tolerate the medicines even though they help them, those would be ideal candidates for the surgery. And the surgery is very beneficial for the right patient. And I guess the other misconception would be that some people think it's more like a cure for the disease. And even patients that go on to get the device, it solves certain problems, but then if they start not doing well down the road, because some of these later stage Parkinson's disease symptoms come on, they're sort of like, hey, you told me this would solve my problems. Well, it really doesn't cure the disease, but it can provide a great deal of quality of life for the right patient for a pretty long time, and really can be a big step up from the medications if they're not working for you.
Kind of along the lines, I had a doctor 2 months ago tell me, well, DBS is still experimental. Can you touch on that? Because I believe it's been around for quite a while. Can you maybe touch on, Dr. Blindauer, how non-experimental it is?
So the DBS has been around for at least 20 years, FDA approved, covered by insurance, so not experimental at all. So it's unfortunate there are people who still think that it's not an approved and well-accepted therapy for Parkinson's.
So if you're thinking about it, it's not like they started last week. This has been in the news a little bit in the last week, and got 2 doctors here, so it's a great question to ask. Sinemet CR is being discontinued by Merck. They think the supply will run out in the fall. What are my options now that Sinemet's not an option anymore?
So Sinemet would be the brand name for Carbidopa Levodopa, and most of the time if either Dr. Blindauer or I prescribe Carbidopa Levodopa CR, you're going to get the generic form of the medicine, and that is still going to be available. They're just stopping the brand formulation. And I'm not aware of anyone who really prescribes the brand. I don't know if you prescribe the brand.
Yeah, rare situations
Yeah.
where the brand seems to work more consistently, but by and large, I do the generics as well.
So that person can just use the generic, and they may already be receiving the generic.
So much ado about nothing. I saw on the news, Sinemet's gone. It really is a generic, so most people they just know it that way because that's what they had way back whenever.
Yeah, and people commonly call it Sinemet, so it creates confusion. Yeah.
But we have had in the last few years, sometimes though the generic Carbidopa CR runs a little bit short by the end of the year because they do manufacture a finite amount, and then sometimes a person just has to switch from a 25-100 to a 50-200 and cut it in half, but then after January, the supply revs up. So we have seen that with the generic. It runs a little low at the end of the year, but it hasn't run out completely.
Thank you for both of you. Here's one, since we had lunch recently, and it's a question that comes up at support groups a lot. I've heard that I shouldn't eat anything within an hour of taking my Carbidopa Levodopa. What kinds of food can I or should I eat when taking my medication, and is there a timing for my medications that I should be aware of?
Okay, I'll answer that one. In the perfect world, you would want to take your Carbidopa Levodopa and wait an hour before you eat. Or if you've eaten something, wait for 2 hours before you take your medication. So why might that not work? Well, you got to get going for the day. So you don't always have the luxury of that amount of time. So in truth, it's protein or amino acids in the food that interferes with the absorption of the levodopa. So if a person says, well, I have to eat at the same time I take my pills because I have to get going or it upsets my stomach, you could eat something low in protein. You could have a slice of toast. You could have saltine crackers. So anything that doesn't have a huge protein content shouldn't slow down or impair the absorption. So there's, again, exceptions to every rule. Sometimes you got to live, you got to get going. You know, you don't always have that luxury of that set time between dosing and eating.
Yeah, and I think different providers are different about what sort of time windows they use. I usually use 30 minutes on either side of a meal where we wouldn't want you to take your medication. If we start to notice that the meals are interfering, then I may get more strict, but you know, I think it's hard on people to follow this rigorous schedule, so I've taken a little bit more lenient approach to win the timing around the meal issue, and then adjust if I think it's causing a problem.
So what I took out of this, next year breakfast is toast, and lunch is crackers. So I hope you all enjoy that.
I didn't say that.
Another kind of Parkinson-related question. Can you explain the difference between a Parkinson's tremor and a non-essential tremor, or essential tremor, sorry, misread that. And can the later become a symptom of Parkinson's later in life?
So a Parkinson's tremor is typically going to be a rest tremor, and that would be tremor when you're relaxing, your limbs are relaxed, whereas essential tremor is typically going to be with use of the hands, and it's usually fairly symmetric in both hands and can involve the head. There can be some overlap there and can cause some confusion, but those would be some fairly general ways to distinguish them. As to whether essential tremor can progress to Parkinson's disease, that has been a long debated topic within the movement disorder world of whether patients with essential tremor are at risk for Parkinson's disease. I think there is some disagreement there, but I think a lot of movement disorder specialists have moved towards thinking that sometimes tremor is mislabeled as essential tremor, and sometimes there can be years of action tremor, so tremor with use of the hands that predates Parkinson's disease, that gets labeled essential tremor, and then the person eventually gets diagnosed with Parkinson's disease. And so that's where I think most of that tie has been coming. And when I diagnose patients with essential tremor, I do not tell them they're at increased risk for Parkinson's disease, and I don't think that's true.
So this next question, I've never seen it before, so I thought I'd ask it because I was very curious. So Dr. Blindauer, Viagra for women. The main ingredient in Viagra, according to this, is dopamine. Will taking Viagra help slow down the symptoms of Parkinson's disease? A lot of very curious people want to know.
Wow. Thank you for giving me that question. If it's a dopaminergic type compound, so it wouldn't slow down the progression, because we already know that about the marketed Parkinson medications. The Sinemet, Carbidopa Levodopa, the dopamine agonists don't slow the progression. Could there be some symptomatic benefit? I wouldn't think so, because I don't think it does primarily have a dopaminergic action. And many of my male patients may be using such products for erectile dysfunction and have not commented that, wow, when I took a dose, I noticed my Parkinson's symptoms changed.
I just like giving you guys the easy questions. That's what we're up here for. One of the next questions, and I think I'll give you a very difficult one, Dr. Finseth. When is someone with Parkinson's disease no longer safe to drive?
Ooh.
And you probably have about 20 answers to that one, so we have plenty of time.
Okay. That is a tough one, and we don't take that decision lightly. Obviously, the loss of ability to drive is a big loss of autonomy. But there are multiple factors about Parkinson's disease that can limit somebody's ability to be safe on the road, and those would include things like reaction time, their ability to process the visual environment. They might have extra movements that are involuntary, and cognitive impairment. So sometimes being able to look at the patient in front of you and being able to say, oh, this person can drive or not, is sometimes hard. And so there, generally I would say that anyone that has been formally diagnosed with dementia, I would encourage them not to be driving. Patients with mild forms of cognitive impairment, I think it's more difficult to say. And I often ask the care partner about what they've noticed, if they've been in the car with the patient while they're driving, whether there's been any kind of close calls, any speeding tickets or anything like that. And then if we're not sure, and then you can always do a more formal assessment. Occupational therapists are able to do something called a driving evaluation, where they're basically able to simulate things, or you can do an in-car evaluation. And that can give you just better data to make your decision about. So that's usually how I approach it, but it's difficult. It's tough to say on a case-by-case basis as to which things to look for that would make it unsafe.
Well, I always joke when people ask me this question as I drive to Milwaukee every day. There's a lot of people who are my age who shouldn't be driving. Mm-hmm. So it really age doesn't matter.
Sure.
So, I think that's a good question for both of you, because you both work with comprehensive Parkinson's disease teams. And one of the questions somebody asked is, what do I do when I have conflicting information from my doctor, my therapist, the people doing the evaluation, and other people within a clinic? How should I handle or resolve that? And we'll start with you, Dr.
Okay.
Blindauer.
Well, the doctor's always right.
So next question.
Okay. So truthfully, you might get different information, and it doesn't always mean that somebody's right and somebody's wrong, because there can be many right answers to treatment of symptoms and approach to Parkinson's. But I can see how it would be disconcerting if you are getting different messages from different members of your care team. I think feeling comfortable asking your doctor to say, well, I heard this from my therapist, or your nurse said this, and I just need to know what the best answer is, and maybe there was some misinformation, but it might be, no, all of these are correct, and it's more of a person's style or approach. But I think good communication with your doctor to clarify that, so you don't feel uncomfortable or have that fear of being misinformed. You think?
Ditto.
Ditto. Ditto. That's very good.
Another question, I think this is probably specific to one person in the audience, but I think it is a decent question. Is there any correlation between Lyme disease as a possible contributing factor to Parkinson's disease, or have you heard anything that's been researched in that way?
That would be a really rare event to have anything resembling Parkinson's disease that's related to Lyme. There are certain viruses or infections that can affect the brain and cause people to have what's called Parkinsonism, and often have other abnormal movements due to an attack on the brain. And those patients are typically very sick, have something called meningitis, and are in an ICU for a long time. And then afterwards often have a very severe brain injury from the virus. The question is probably aimed more at this thought that people have chronic Lyme disease, and there are, I think, disagreements about the validity of what is being proclaimed. But my personal opinion is that would be kind of part of this large field of what's called pseudo-medicine. I would even put CBD in there. So there are some available stem cell treatments. And these things are marketed to people with diseases, and it is a big problem. I would encourage patients to come and talk to us about that. I'm usually very frank about what I think of some of these things, as I think that it's dangerous to kind of pursue some of these treatments outside of more established medical treatment, and that people should really be using treatments that are more evidence-based.
You said two things there that I think I have follow-up questions on.
Sure.
One of them I can probably start with Dr. Blindauer. You mentioned Parkinsonism. Somebody asked, what is the difference between Parkinson's disease and PSP, which I believe PSP is a Parkinsonism. I'll hand that one to you.
Okay. So Parkinsonism is the most generic term for meaning anything that looks Parkinson-like. So a person is manifesting perhaps some shuffling in their gait, some rigidity, slowness of movement, and some tremor. So under the umbrella of Parkinsonism, one of those categories is Parkinson's disease. So the garden variety Parkinson's that we all know is caused by the Lewy bodies and the loss of the dopamine neurons. But there's other conditions that can make somebody look Parkinson-like. So if a patient has a stroke in the area of the brain called the basal ganglia, or if they have a lot of small strokes in diffuse areas of the brain, they can develop what's called vascular Parkinsonism. So it looks like Parkinson's, but it was strokes that have caused it, and not the typical pathology of Parkinson's. There are certain medications that block dopamine that can cause drug-induced Parkinsonism that can be reversible. And then in the category of Parkinsonism are what we call the atypical or the Parkinson plus, and that would be conditions like multisystem atrophy or progressive supranuclear palsy, corticobasal degeneration. Those are some of the names of those other conditions that might initially look like Parkinson's, but then they take a fork in the road and progress in a bit of a different manner later in the course of the disease.
Can you spell those? No.
Or say them 3 times real fast. Yeah.
That's why I left it for you. I abbreviated PSP, so it was. Dr. Finseth, when you were talking about the last question, you had mentioned stem cells. So we've had a few questions. Where are we at with stem cell therapy? But I also want to touch on, I'm really surprised that my local chiropractor and his stem cell therapy isn't a cure. Is that what you were saying?
Yeah. Stem cells is an active avenue of research for Parkinson's disease. They've tried it in clinical trials where they directly inject stem cells into the brain, and there were kind of mixed results with that. And now they are currently looking at trying to target the brain with stem cells that can turn into to dopamine cells. But it's purely in a research stage, and if you are being offered, or if there's any commercially available stem cells for Parkinson's disease, that is being done really without any evidence to support its use. We can't say how safe that would be, and it often costs a lot of money. I think that it's likely that people are trying to profit on this. So I would, and some of these places are now listing themselves on a typical website called clinicaltrials.gov. That is where we usually go to look for research trials, and it has created some confusion there as to what is a valid research study. If you have any questions about that, please talk with your doctor about whether that would be a good idea.
Yes, I think just buyer beware, because there are the anti-aging clinics that you can pay out of pocket for a stem cell infusion, but no safety. We don't have any information knowing it's effective. So I would be fearful for somebody's health, and then just also the money that you would be spending for no good reason.
Thank you. I think that was very well answered. Yeah. One of the questions that came up today, and I'll try and paraphrase it, they said, people always say, Parkinson's doesn't kill. You don't die from Parkinson's. And then they list, falling, choking, refusing to eat, a number of other things. Can you answer what that means? Parkinson's won't kill you. Can you kind of explain what the thought process is on that? And then the question at the bottom is, well, then what do I die from? So if you can touch on that.
Wow. So I think what that question is getting at is Parkinson's doesn't really substantially shorten a person's lifespan, since we have so many good treatments to address the symptoms. Before the onset of use of levodopa, a person probably passed away fairly quickly after the diagnosis because there wasn't anything to improve your mobility, rigidity, and so forth. Now with modern treatments, we're able to allow patients to live a good, long, essentially normal life. So what do we die from? Well, as we get older, people still have heart attacks, they have strokes, or in a person with more advanced Parkinson's, maybe a person does develop pneumonia, because if you're more sedentary, you're more prone to get infections. So part of, I think, what's startling is when you see an obituary and it says somebody died from the complications of Parkinson's. And part of that, not to be so grim, but we have to fill out a death certificate. We're not allowed to use pneumonia and the terms that people usually die from. We're forced to use that terminology, that a person has died from complications of Parkinson's, or you don't say heart failure. Well, what caused the heart failure, and so forth. So I think the encouraging news is that lifespan isn't significantly shortened, and for many people with Parkinson's, they pass away from what we all do as we get older, heart attack, stroke, and so forth. Would you agree, or have?
Yeah, I agree. I think when Parkinson's does contribute to shortening someone's life, it's often from a complication like a fall, and then you have to have a big surgery, and the longer you're in the hospital, the more things that can kind of go wrong there. And so, as Parkinson's advances, it can shorten someone's lifespan, but typically it's something else.
The next question. Every disease has stages. What guidelines do you use for the Parkinson's stages? I have things to do before I go and want to know. God bless you, whoever asked it. You guys did great.
So the traditional staging of Parkinson's disease is divided up into 5 stages. And the first stage would be when it just affects one side of the body. the second stage when it affects both sides of the body. And then the rest of the staging is really based on balance and mobility, where stage 3 would be there starts to be some balance impairment. Stage 4, where you start to have the need to use an assisted device to walk, and stage 5 when you'd be wheelchair bound. And that is still the most commonly used staging system. A lot of people progress from stage 1 to stage 2 very quickly, and then might be in stage 2 and stage 3 and 4 for the longest period of time.
And it's called the Honeyar stage. So if you ever look it up, and it's not linear. Because a person can be in stage 2 for an incredibly long time,
Right.
and then you can also go between stages whether your medications are on or off. So I don't like to use it so much clinically. I think it's more helpful for research as you're figuring out what stage a patient is before entering a clinical trial, but I don't know that it's all that helpful in the clinical setting.
Right. One person with stage 2 can look completely different from another person in stage 2, and it doesn't have that much relevance to us.
Yeah.
Jumping off of that, I hear a lot of times, not from your colleagues and yourselves and other people, you see one patient with Parkinson's, you've seen one patient with Parkinson's disease. Can you maybe touch on what does that mean? Because I always try and tell people, I'm like, you can all sit at the table together and you all have different symptoms, different medications. Can you maybe touch a little bit more what that means for progression? Because I think people always look to their neighbor, what am I going to be like? And that's probably not the best barometer.
So Parkinson's is very unique. So you might say, well, my friend had this symptom and then that symptom and took these medications and that's what had worked or that's what didn't work. I say, well, that might not even apply to you because everybody with Parkinson's has their own journey in the course of their illness as far as what symptom might come first, what occurs next in the progression, what medications work. So if somebody says, well, I've seen one with Parkinson's, I've seen them all, that's as far from the truth as you can get.
Yeah, absolutely. Everybody is very unique it's interesting to think about, why that is, but the short answer is we're not really sure. And that makes it very difficult in terms of guiding patients, especially when they're initially diagnosed. Everybody wants to know what the future is going to look like, and it's so hard to say, and you really need some years with that patient to be able to have even a semblance of an answer.
Another question. I've noticed since I've been diagnosed with Parkinson's, I have urges. The way the person put it is, I don't drink alcohol every day, but when I have one, I can't wait to have another one and another one. Is this related to my Parkinson's disease or one of the medications? Or is there something else? I'm not an alcoholic, I don't drink every day, but when I have one, I have to have another one.
Is it my turn?
Sure.
Okay. That sounds like impulse control or a loss of control when this person starts to drink. Impulse control problems are common in Parkinson's disease, and they are aggravated by mainly the medications called dopamine agonists, but also to a certain degree, levodopa can do this as well. So if that person is on pramipexole, ropinirole, rotigotine, those would be medicines that they might want to reduce, and that might help. And then sometimes we add medications that may help with that impulse control. Some of the traditional antidepressants or medication called zonisamide is one I've used, might help with that impulse control problem if you can't solve it with altering their other medications.
Can you touch on what other areas impulse control may be touched by other than alcohol is not the only thing?
Sure. So you can have hypersexuality, gambling, or any sort of like risky behavior, shopping, with now that we have electronics on us at all time, there's like compulsive email checking, or people can be very compulsive about how they document things. Like we can often see it with patients who have documented everything for the past, month for us to review. That can all be a part of this impulse control problem. And it can be very hard on patients. It's something we take quite seriously, as there have been bad outcomes from that. Did I hit all the typical ones?
I think so. And it's maybe 15, 20 years ago we didn't realize it existed, and now that we do, I'm sure you forewarn your patients. You say, if there's any behavior that you're doing that seems uncharacteristic, please let me know, because it could be the medication. Because as you mentioned, sometimes bad things happen where people spend way too much money or gambling, and it can have a detrimental effect on their life and relationships. And sometimes the impulse control can even be something that seems positive, like somebody suddenly starts cleaning and they can't stop cleaning. And I always joke that those are the patients that I invite over to my house, rather than adjust the medication. But it's not always a negative, but it's like, is there just something you do that you can't stop? Because you don't have to stay up till midnight to clean the house. You can go to bed and you can finish the task in the morning. But it is treatable, and I think not feeling ashamed if there's some behavior that you're doing and you're not sure, could this be my medication? Could it be my Parkinson's? Just ask. Because I think we're used to hearing those questions, we're used to dealing with that, and we certainly wouldn't want that to go on and on without knowing about it and not helping you.
All right, just a couple more questions. We're getting close. One of the questions, and I'll start with you, Dr. Blindauer. Given the importance of exercise, can you please compare silver sneakers to some of the PD-specific exercise programs and what the benefits may be from both of those?
Wow, okay. So just bottom line, exercise is extremely helpful for Parkinson's. So I would start with the basic: doing something is better than doing nothing. So that's where the silver sneakers comes in. So a person is better to do that than to be completely sedentary. But the Parkinson-related exercise classes are often run by physical therapists or people who are trained to know what movements would be helpful to improve flexibility, or what exercises might improve balance or improve the speed of movement. So many of the exercise classes are geared toward the big therapy, and they're sort of a carryover or a power program and the rock steady boxing. So it's tailored more toward what would be helpful for someone with PD, but I wouldn't negate the benefit of doing some exercise versus none.
Thank you. One last question for you, Dr. Finseth. Again, it's a real easy one. Somebody in my support group was diagnosed with Parkinson's disease 6 years ago, was just told by her recent doctor she doesn't have it, but they're not sure what she has. What would you recommend for that individual, and how do you do that if you have somebody in your clinic who maybe has had it for a long time and also finds out that that the diagnosis was wrong? It actually is, maybe a Parkinsonism or something like that. What kind of support do they have, and what would you recommend that individual does?
So that's a tough question.
Wanted to end on a real finger for him.
Yeah. Well, so it is an interesting predicament that person is in, and often when people get the diagnosis of Parkinson's disease, it sort of becomes part of their identity, and they invest a lot of effort and time into it, and so to get then undiagnosed can be taken very personally by a patient. While most people viewing that from the outside would be like, great. It also depends on sort of what that other diagnosis would be. So I think there is a subgroup of patients who have had predominantly tremor, and that tremor responded to levodopa, but they didn't seem to get worse over time, and with the more widespread use of something called a DAT scan, some of those patients have been shown not to have Parkinson's disease. And in that case, that's really great news for that patient. Whereas sometimes people get diagnosed with Parkinson's disease, and then they start developing more severe symptoms earlier and suggesting a more, one of these Parkinsonism conditions that Dr. Blindauer talked about. And that can be very hard to sort of receive that diagnosis instead. But the care surrounding that would be very similar to how we care for Parkinson's disease, and you would stay with the same doctor. And there are other diagnoses that can mimic Parkinson's disease, but I think a lot of it depends on which one that is. But so it's difficult for me to advise that patient what to do.
It was a tough question.
Yeah.
I do.
Yeah.
Well answered.
And as you said, I mean, people, their identity, I've had people in a support group I work with go, well, I found out I have this, can I still come? And it's like, absolutely, you've grown with these people, please still come.
Right.
So,
And they still have those same symptoms. You don't have to disconnect from the Parkinson's disease network just because your diagnosis changed.
all right, so I'm going to give you both the toughest question I've been asked for the rest of the day. This is our last question, and I'll start with Dr. Blindauer. What do you see as hopeful or good news for Parkinson's disease going in the future?
So what I see as hopeful is what I had already talked about a little bit earlier with research and the fact that there's so much effort now that's looking into impacting the pathology and trying to slow the progression of the disease. So I'm excited and just motivated by the fact that we're breaking new ground and really digging into making a difference for the longevity of a person with Parkinson's and not just merely addressing the symptoms today.
Yeah, I also think that having hope regarding these new avenues of research and earlier detection of potentially Parkinson's disease before even onset of movement symptoms will hopefully potentially be able to allow us to prevent people from getting Parkinson's disease. And for people living with Parkinson's disease today, I think there have been a lot of great groups with the Wisconsin Parkinsons Association among them that have, I think, gained a lot of traction over the last 10 years, are really providing a lot of support for people, providing support for caregivers, and just all the love and devotion I see from all the caregivers on a day-to-day basis really fills me with hope.
Can we give Dr. Blindauer and Dr. Finseth a hand? Here's where it gets awkward. Gary and I were never in a relay team, but I have to give him, there you go.
Yeah. Thank you, Jeremy, and thank you, doctors. That was fantastic. You're just not going to get, 45 minutes with two of the top experts in our state. So thank you. We are honored to have you here. So just a couple of announcements, and we're going to get you out of here. There's some lost and found items. So if you lost a purse, lost any clothing items, there's a couple of clothing items. So check before you leave. See if you're missing anything. A couple of the door prizes were in claim, so check your envelopes in your programs for a heart on your envelope. If you have that, you've won something. And if you didn't, I know some of the programs got taken. If you need a bag, we got more at the desk, so stop there. Friday, August 23rd is our next Living with Parkinson's program. That's a half-day program. That's going to be in West Bend. It's going to be at the Washington County Fair Park. Again, it's Friday, August 23rd from 9 to noon. So think about coming out there. And our big announcement today is going to be that this program for the last 7 years and for most of the last 33 years has been held in southeast Wisconsin, mostly in the Milwaukee area. We're going to take it on the road next year. We're going to take it to Appleton, to the Fox Cities area. And those of you, most of the folks here today are from this area, but the second largest population comes from Fox Cities. We got great programs going on there. We are Wisconsin Parkinson Association, so we got to bounce it around a little bit. So it's going to be up there. You watch for details on that. But we're not abandoning this area by any means. We're going to June 20th, we got a date on it, June 20th, so write that down in Appleton. But we're going to be doing a break brand new program in this area called the Renew Retreat. We're partnering with another organization, and it's going to be an all-day, one day event for both care partners and folks with Parkinson's disease, with programs for both going on at the same time. So it's going to be a really cool thing. That's going to be happening in that area, and that's why we wanted to as well move the program to Appleton. So thank you all for coming out today. Know it was a long day, but we also heard from you that it's been a great day for you. Drive safely. Thanks for coming.